When you think about sleep, you probably picture brainwaves on an EEG, but here's the truth. The brain is the conductor, but the lungs are the brass section. Loud, powerful, and impossible to ignore when something goes wrong. The respiratory system keeps oxygen flowing in, CO2 moving out, and it's at the very core of what we monitor during a polysomnogram. For RPSGTs, this is where much of the action happens: obstructive events, desaturations, and hypoventilation. So today, we'll break it down into 3 parts: the airways, the mechanics of breathing, and gas exchange that keeps patients alive. First up is the upper respiratory tract. This is the entryway and conditioning center for air. The nares and nostrils are the gateway to airflow. The turbinates or conchae are the bony shelves that warm, humidify, and filter incoming air. Sinuses are air-filled cavities that help condition inspired air. The pharynx is actually broken down into 3 different sections: the nasopharynx, which is right behind the nasal cavity, the oropharynx directly behind the mouth, and the hypopharynx, the lowest section just above the larynx. The larynx is often referred to as the voice box, containing the vocal cords and guarding the airway during swallowing. Most obstructive sleep apnea occurs in the pharynx, where the soft tissue collapses and blocks airflow. Next, let's go a little deeper: the lower respiratory tract. The trachea is the windpipe delivering air to the bronchi. The bronchi branch into the right and left lungs. The lungs home the bronchioles, or branches of the bronchi, and the alveoli. The alveoli are tiny air sacs where gas exchange happens across an alveolar capillary membrane. Gas exchange efficiency is directly connected to the health of the lungs, alveoli, and bronchi. Problems in the lower respiratory tract can cause diffusion issues with CO2 and O2. Alright, let's talk about ventilation, the art and science of moving air in and out of the lungs. Without ventilation, there's no oxygen delivery and no carbon dioxide removal. Breathing in all starts with the diaphragm. When it contracts, it flattens downward, expanding the chest cavity. The intercostal muscles pitch in as well by lifting the rib cage. The result is a drop in inner thoracic pressure, and air rushes into the lungs like shoppers on Black Friday. Watching respiratory effort, inspiration on the PSG is important for determining apnea types. When analyzing respiratory effort, we use RIP belts, which is recommended by the ASM. However, intercostal EMGs may be utilized to differentiate between central and obstructive apneas. At rest, expiration is a passive process. Elastic recoil of the lungs and chest wall pushes air out without any special effort. During exercise, distress, or obstructive events, the abdominal muscles, the rectus abdominis and obliques, contract and force air out. The intercostal muscles pull the ribs down and squeeze the thorax smaller. If you see strong abdominal or belly pushing on a PSG, that's typically a sign of increased expiratory effort. That's a red flag for obstructive or restrictive lung mechanics. During wake, we have a strong ventilatory drive, higher muscle tone, and a stable airway. During a sleep, especially during REM, muscle tone drops, including the pharyngeal dilators. The airway gets floppy, and obstruction risk goes up. That's why REM is apnea's favorite party spot. The diaphragm is the primary muscle for breathing. The external intercostals assist inspiration by expanding the rib cage. Auxiliary muscles like the sternocleidomastoid and scalenes are normally quiet, but in distress, they fire up. If you see them visually contracting during a PSG, that's not just extra effort, that's a sign of respiratory distress. Expiration at rest is usually passive thanks to elastic recoil. During forced expiration, the abdominals and the internal intercostals take over. Paradoxical breathing is observed when the abdomen rises and the chest falls, and vice versa. This is a sign of diaphragm fatigue or upper airway obstruction. Breathing isn't just air in and air out. Pulmonary physiology breaks it down into volumes, which are single measurable compartments, and capacities, which are a combination of these volumes. For RPSGTs, knowing the numbers helps you understand ventilatory patterns, hypoventilation, and why certain patients desaturate faster than others. Let's look at lung volumes. Tidal volume, or VT, is somewhere between 350 to 500 milliliters in adults. This refers to the volume of air that moves in and out during a normal breath. Inspiratory reserve volume, or IRV, is the extra air you can inhale after a normal inspiration. Think of it as like a deep breath. Expiratory reserve volume, or ERV, is the extra air you can push out after normal exhalation. This is the volume you might use to blow out a birthday candle. Your residual volume, or RV, is the amount of air in the lungs after maximal exhalation. This volume never leaves, and it keeps the alveoli inflated so they don't collapse. Next, let's talk about lung capacities. These are combination volumes. Inspiratory capacity, or IC, is tidal volume plus inspiratory reserve volume. Basically, the amount of air that you can inhale after a normal exhalation. Functional residual capacity, or FRC, is the expiratory reserve volume plus the residual volume. This is the reserve tank left in the lungs after normal exhalation. This helps maintain oxygen exchange between breaths. Vital capacity, or VC, is tidal volume plus inspiratory volume plus expiratory volume. This is the max amount of air that you can move in and out of your lungs voluntarily. Total lung capacity, or TLC, is all lung volumes combined. Tidal volume, inspiratory reserve volume, expiratory reserve volume, and residual volume. The full volume that the lungs can possibly hold. Obesity lowers functional residual capacity, meaning that desaturations happen faster when airways collapse. COPD increases residual volume due to air trapping, which alters baseline gas exchange. In pediatrics, these volumes are obviously smaller, with higher respiratory rates, so oxygen reserves deplete quickly. In hypoventilation syndromes like OHS and neuromuscular diseases, you'll see a reduced tidal volume, or vital capacity, which leads to chronic hypoxemia and hypercapnia. Minute ventilation is tidal volume times the respiratory rate. This refers to the total amount of air moved in and out per minute. Let's look at an example patient. This patient has a tidal volume of 500 milliliters and a respiratory rate of 12 breaths per minute. This would result in a minute ventilation of 600 milliliters, or 6 liters per minute. Work of breathing refers to the energy that it takes to ventilate. If an airway is narrowed or chest wall is stiff, or let's say lungs lose compliance, the work of breathing goes up. High work of breathing on a PSG can appear as paradoxical breathing or the use of auxiliary muscles. This matters in differentiating OSA from hypoventilation syndromes. The minute ventilation calculation is used for advanced PAP modalities like VAPs. Breathing isn't just muscles doing their thing. It's tightly regulated by the brainstem centers in the pons and medulla. The medulla respiratory centers include the dorsal respiratory group, or DRG. This generates basic rhythms for inspiration. The ventral respiratory group, or VRG, helps forced breathing. The pontine respiratory centers are centers in the pons that fine-tune rhythm, smoothing transitions between inspiration and expiration. The pons and medulla don't work in isolation. They are constantly adjusting based off of input from receptors. Central receptors in the medulla monitor CO2 and pH in cerebrospinal fluid. A rise in CO2 increases the drive to breathe. Peripheral receptors in the carotid and aortic bodies monitor O2, CO2, and pH changes in the blood. Low oxygen, high CO2, or changes in pH trigger signals to the medulla to increase ventilation. Mechanoreceptors include the pulmonary stretch receptors. These send signals via the vagus nerve to the medulla and pons when the lungs inflate too much. This triggers the Herring-Brewer reflex to prevent overinflation. Irritant receptors send smoke, dust, or other irritants that stimulate coughing or rapid, shallow breathing. Juxtacapillary receptors, also known as J receptors, detect fluid or congestion in the alveoli. This can increase breathing rate and cause dyspnea. The chest wall and diaphragm also contain mechanoreceptors. These provide feedback on muscle load and movement. This helps the medulla adjust effort if breathing becomes hard. So what is the outcome? Together, this feedback loop allows the pons and medulla to adjust the rate and depth of breathing in real time. If CO2 rises, they increase respiratory rate and tidal volume, encouraging ventilation to reduce CO2. If the lungs stretch too much, they signal early exhalation. If O2 drops, they boost ventilatory drive. Central apneas occur when medullary output fails, which results with no respiratory effort on the PSG. Obstructive apneas occur when there's a blockage in the airway despite strong medullary drive. This is seen on the PSG when there's effort but no airflow. In Cheney-Stokes respiration, unstable feedback loops between the chemoreceptors and the brainstem cause this characteristic crescendo-decrescendo pattern that we see on the PSG. Finally, we get to the business end gas exchange. In the alveoli, inspired oxygen passes or diffuses into the bloodstream, while carbon dioxide goes from the bloodstream into the lungs to be exhaled. The oxyhemoglobin dissociation curve. This curve illustrates the relationship between PaO2 and oxygen saturation. If the curve shifts right, it reduces an affinity for O2. This is seen in fevers, acidosis, and high CO2 retention. If the curve shifts to the left, it increases affinity for O2, seen in alkalosis or hypothermia. Here are some key blood gas values to memorize. PaCO2 should be somewhere between 35 to 45 millimeters of mercury. PaO2 should be between 80 to 100 millimeters of mercury. pH levels should be between 7.35 and 7.45. HCO3 should be between 22 to 26 milliequivalents per liter. SpO2 values should be between 95 to 100%. Arterial blood gas, or ABGs, are the gold standard for assessing ventilation and oxygenation, allowing us to see blood gas values. But because ABGs are invasive, typically end-tidal CO2 or transcutaneous monitoring is used to evaluate CO2 on the PSG, and SpO2 is used to monitor oxygen saturation. Hypoventilation results in elevated PaCO2 levels. Apnea events typically drop SpO2 and PaO2 levels. To evaluate for chronic hypoventilation disorders like obesity hypoventilation syndrome, we typically use CO2 monitoring like end-tidal CO2 or transcutaneous, or if we have the ability, an ABG would be ideal. The respiratory system is the front line for sleep disorder breathing. From airway anatomy to the mechanics of ventilation to the chemistry of gas exchange, it all comes together in the signals we monitor. For the RPSGT, mastering these systems means that you can recognize where the problem starts, how it shows up on the PSG tracings, and how it affects the patient's oxygen and CO2 balance. Next, we'll turn to the anatomy of the head, neck, torso, and limbs to see how we monitor those on the PSG. See you there.